Hi everyone, I'm George Milner and welcome back to the Pager podcast. So in this episode we speak to Dr Peter Hodkinson, who was the UK's first ever consultant in Aviation and Space Medicine. He is the head of the Division of Aerospace Medicine at King's College London and has previously worked for 17 years with the Royal Air Force in the UK. Aerospace medicine is such a rapidly expanding field which encompasses everything from assessing fitnesses of passengers and pilots to fly, to investigating and predicting the effects of space travel on the human body. And we talk about all of these things in this podcast. We talk about picking people for space travel and astronaut selection, some occupational health aspects of space flight. We also talk a bit more about space physiology and adaptation to space travel, both in the long and short term, and potentially predicting what the effects of longer term missions might be, for example, to Mars. We hope you enjoy the episode. As ever, if you like this podcast, then do leave us a review or rating or share it with a friend. All these things go such a long way for us, so we really appreciate it. Dr Hodkinson, welcome to the podcast. Thanks so much for joining me today.
Very welcome. Thanks for having me. Looking forward to it.
You might not be surprised to know, but you're the first consultant in aviation and space medicine that we've had on the podcast before. So I was wondering if you could just briefly introduce what you do on a day-to-day basis in your work.
So I spent 17 years in the Royal Air Force, which is where I trained in aviation and space medicine. And I'm now working at King's College London as head of aerospace medicine. So it's not the easiest question to answer because everyone that works in the field will do a different range of activities on a day-to-day basis, and other colleagues that work in the Civil Aviation Authority again will have a different range of activities, and again that will be different to those that work at the European Space Agency or NASA or other organisations. So I talk now about what I do at King's. We have a mix of clinical research and educational activities. So a lot of my time at the moment is spent supporting our postgraduate diploma in aerospace medicine and our short courses for aeromedical examiners, so people that do the annual aircrew medicals, either for private pilots or commercial pilots. So it's a mix of teaching content for those, assignments, marking, and then also trying to work on the research dissertations for the Masters in Aerospace Medicine or for the Human and Applied Physiology Masters students that we also help supervise at King's College London.
Mm-hmm. So quite a diverse range of things there. And how did you get into this in the first place? Because looking through my placement schedules, I don't seem to see a placement in aviation and space medicine there yet.
Yeah, no, sadly not. That would be great if we could get that into all of the medical schools. The medical school curriculums are so jam-packed, it's hard kind of getting anything in. We have started to try and bring this into some of the med schools where we can, but it is challenging. So for me, I did an intercalated Bachelor of Science degree in physiology up at Edinburgh. And really enjoyed the slight change from the medical school curriculum. I'd always been interested in the outdoors and kind of extreme environments. And while I was doing the physiology BSc, we did a sport and exercise module. And then one of the tutors pointed me towards a course because I'd said I was interested in this kind of extreme environment physiology, which was the Human and Applied Physiology Masters at King's. So I came down to a conference in London in '99 and met Kevin Fong and Simon Evans, who were just at the start of their journeys into space physiology and medicine. And then I met the Professor John Ernsting, who was running the physiology course at that time. And essentially it was an advert: do you want to be decompressed to high altitude, spun round on human carrying centrifuges and go diving with the Royal Navy and learn all about the physiology of medicine? And I was like, yes, definitely. And then on the course, it was taught alongside the diploma in aerospace medicine that I now run. And so I got exposure to the doctors that worked in the Royal Air Force in aviation medicine, and the career path kind of unfolded before me as I was doing the masters, and then kind of set me on the path that I've done ever since, with a mix of extreme environment physiology, expedition medicine, aviation, space medicine.
And I think I'd love to touch upon a few of those things kind of throughout the podcast. Certainly, perhaps talk a little bit about space physiology and also some of the kind of decision making that goes into determining, I guess, whether people should go into space in the first place, or indeed it overlaps with people being fit to fly, whether it's passengers or pilots. And perhaps we could take that to begin with, because spaceflight is not a routine activity. And I was wondering how you think about actually whether it is suitable for somebody potentially with a medical condition or, I don't know, of different ages to go into what perhaps might be quite an alien environment to what their physiology is used to.
Yep, certainly. There are many different aspects to those considerations. Coming at it to start with from the medical perspective, what our role is to help manage the risk of the human within the system. So whether that is the pilot that's operating or the astronauts operating the vehicle and the associated medical standards you might have for that, depending on what the risk is associated with something going wrong with that individual, as opposed to someone who's in the back of the vehicle and one of the passengers that has a medical incident. So that the impact on the safety for the individual is considered, but also the impact on the safety for everyone else on board, and then the broader impact on whether you can achieve your mission or not. So there's different elements there that you might take into account that give you a different target for what risk would be acceptable or not. They're all scenario specific considerations. So a military flight operation will have a slightly different set of what is acceptable or unacceptable risk compared with commercial aviation. That will be slightly different to private flying, and that will be different from space flight. And then within space flight, if you're looking at a career professional astronaut, that will be a different set of acceptable risks to a space tourist that's going up for maybe a couple of weeks, or maybe going up for a few minutes on one of the suborbital flights. And they'll be different again from what we're seeing with kind of Axiom Space in the States, where you're looking at space tourists almost, but who are going up to do a professional astronaut role, albeit they're paying for themselves to go up, is some of the stuff that Axiom are looking to do, which is an interesting, slightly different paradigm shift. And the medical standards have shifted over time to mirror all of those bits. So in the early days, you're selecting professional pilots or astronauts who are going to hopefully remain fit for as long a career as possible, because there's a lot of money being invested in them. And that hopefully gives you the idea that we're stepping away from purely medical considerations here. It's the broader system type bits that we're thinking about. So that's where the employing organisation is going to invest a lot of money in the person. They want to try and have them fit and able to work safely for as long as they can, as opposed to someone who may be paying to go up for a short duration trip, or where they're willing to take on the risk themselves if it's not putting other people at risk. So there's lots of different kind of trade-offs there as to what's acceptable or not. So talked a little bit about scenario specific consideration in terms of the different flight profiles, the different populations. You can also think about the different organizations or structures, and that will be different from a government to military to commercial potentially.
I'm sorry for landing you with a very broad question to start off with. Maybe we could focus down on a couple of bits, because you've got potentially the ability to select a very small number of people from an enormous pool of applicants. And I wonder actually if there is this balance between, in theory, you could probably eliminate people from that process for quite trivial things on the basis of uncertainty, really. Okay, we don't know quite what the effect of this is going to be in space. We don't know what the effect of this is going to be long term. How do you balance actually just being perhaps overly discriminatory in this process?
Yeah, certainly historically, the medical approach and medical standards were very conservative, and any hint of concern or doubt or risk, they would select them out. And this is both in the space setting as well as in the aviation setting. And what we've thankfully seen over the last few decades is a shift to a more kind of evidence-based approach, where you're looking to permit people and enable people to operate in these environments where it is safe for them to do so, and they can functionally do the role, which takes a bit more nuanced thought and sometimes takes a bit more research to inform those decisions. But it's definitely a pattern we've seen across the whole of aerospace, where we're starting to revisit and have more nuanced guidelines for these bits. And in part, the boundaries are being pushed where organisations are willing to invest the resource to look at it and to support it. One of the bits that I'd highlight at the moment would be the European Space Agency para-astronaut feasibility project, where they're looking to explore how they can break down the barriers that historically have been in place for people with physical impairments to not be able to fly in space. And we've already seen a lot of changes in the aviation setting, where different organisations are enabling people with physical impairments to fly where historically they wouldn't have been able to.
And I think this expands even further out into kind of the wider world, whether it's standards for other aspects of kind of military employment or driving heavy goods vehicles, anything that potentially entails risk to other individuals around. And one thing that came to mind was actually looking at the Italian leagues and Christian Eriksen, who had an ICD implanted recently following his collapse, not being allowed to compete within the Italian leagues, but could compete in the Premier League, as an example. So I don't think these decisions are just isolated to aerospace medicine, but perhaps they're particularly kind of pressing considerations.
Yeah, absolutely. There are so many overlaps with different domains, and it's one of the really important bits within the field of aerospace medicine is that we have people from different professional backgrounds and from different cultures and parts of the world that contribute to help balance off all of those different inputs and views. It does mean you're never going to get everyone to agree, and there'll always potentially be different approaches in different parts of the world. And that's fine.
And when you talk about a kind of more evidence-based framework for making these decisions, I'm curious what sorts of evidence you're using, because you can imagine a situation in which we perhaps have quite a small sample size of kind of data from human physiology in space, and if you were to say, okay, we're going to add on top of that one particular medical condition, then suddenly perhaps the pool of people falls even further and perhaps falls to zero, particularly if those individuals have not been able to go into space in the past.
Yes, absolutely. Dealing with uncertainty and gaps in the evidence base is a huge problem in medicine in general, but particularly so in aerospace medicine, either due to a lack of resource funding, prioritization to look at the areas, or even where there is resource and support to do the work, just the limited numbers of people that have ever been into space. You're talking about kind of 580 people or so. So there's not many people, even if they'd all taken part in the studies. So a lot of the evidence base for spaceflight will come from terrestrial research analogues, or just the application of terrestrial health data with some interpretation to put it into the spaceflight environment. So there's huge kind of gaps in the applicability of that evidence base. And as it has historically been so in the aviation setting as well, but aviation has started to address those over the last few decades. So with advances in treatment options for diabetes, for example, they've been able to do studies rather than just general population studies on diabetes and risk of incapacitation, etc. They can start to look at building up the evidence base through testing and monitoring of pilots in commercial operations, in commercial aircraft operations, to check whether it's safe or not and feasible for them to be monitoring their glucose in flight, and therefore permit people to continue flying as professional pilots where historically they would have been declared unfit. And that's a kind of mix of technology improvements, but also actively doing the research to help provide the evidence that it's safe for people with these different medical conditions or treatments to be able to do their jobs. But it's tricky, and there's often areas where there isn't the research available, or the research will often be epidemiological research about incapacitation risk, for example, in terrestrial populations. So you've got to look at, well, is the population relevant? How does the environmental exposure that they'll have in the flight environment change what that incapacitation risk would be. And often there isn't the direct evidence to support those steps. So the positives and negatives, it means there's lots more work that people could do if they're interested in the field, but it means that the decision making is more challenging, and that's why it is historically often erred more on the conservative side.
In your summary of aerospace medicine in the British Journal of Anaesthesia, I think you list a couple of examples of patients. Actually, I should call them astronauts instead in this case, but people have been into space, but actually with quite a number of different medical conditions that you might have looked at on paper and thought this would raise alarm bells at the NASA or ESA HQ.
Yes, yeah, absolutely. And I think there've been professional astronauts, you rarely get the information in the public domain about what medical conditions they've had and therefore what's been permitted to actually fly. The ones that have been published there, I think you're referring to, are more of the commercial astronauts, where they were happy to share as part of their journey to try and break down barriers for non-professional astronauts flying in space. They wanted to share their medical journeys and the information that went with it. They're fascinating articles to read, but again, it comes back to what we were saying earlier on in terms of the scenario-specific considerations and looking at the risks of a given situation for a given patient to see what is acceptable or not in that particular scenario.
Yes, and you can imagine if only 580 people, as you said, have been into space, then you don't need very many data points to work out exactly who you're referring to potentially. So
Yes.
you need to be careful there. And I wonder more broadly, does this, in a way we're talking about occupational health, does this perhaps change the relationship that a doctor might have with a patient, in that they might somewhat be seen as a gatekeeper to potentially their career in a way? And I'm wondering if this brings up issues along the way for somebody who has spent potentially a decade or longer training for a particular role. The idea that something that's completely out of their control could take it away from them, I think, is quite a scary one. And as much as you can make reasonable allowances for medical conditions and others' disabilities, there's only so far that you can obviously go within this system if their role is quite a demanding one.
Yep, absolutely. And there's lots of different aspects that you could talk about and pick apart in the bits you've just said there. Certainly, historically and continuing to be so, pilots can often be afraid or concerned about talking to the doctor that signs them off as fit to fly or not, because when they go to see them, they walk in the office, an operational pilot, they might walk out of the office not being able to fly. So when your whole livelihood and often reason for getting out of bed in the morning, because they normally do what they love as pilots, the idea that someone could take that away from them clearly is going to be quite concerning. There are concerns about whether people might try and hide things from the doctors that look after them from a regulatory perspective. There are various kind of safety nets in place that you can try and address that. There are legal obligations on pilots to declare these things, but a lot of it comes down to culture and relationships between the medical staff and the aircrew. So in that particular role, as you described, you are effectively a gatekeeper. So if you are working as an aeromedical examiner, an AME, doing annual aircrew medicals, you're acting on behalf of, in the UK, the Civil Aviation Authority, and your role is one of public safety. So although the pilots come to you to get their medical fitness reviewed, you're working on behalf of the Civil Aviation Authority to represent flight safety. So you aren't there to be the pilot advocate, you're there to protect people that are flying or the public on the ground. So that's a difficult one, but you can manage it through a good working relationship with them. And it's normally a matter of perception and understanding from the pilots that if you're saying they're not fit to fly at that particular time, it's because it's not safe for them to be fit to fly. And you will then help them work through the steps they need to get back to the point where they are safe and fit to fly. And normally depending on the organisation, you have the opportunity to build those relationships and build and develop that level of trust with the pilot populations. Other organisations, the same doctors may be the treating doctors and the regulatory representatives. So in the UK military, for example, their GP will be the same person that does their annual medicals. So there's less opportunity for conditions to be hidden unless they were to be seeing private doctors, which is a different set of considerations again. But it's a challenge, and it's something that you always have to think about and be aware of when you're seeing the pilots as patients from a AME perspective. That they might try
I can see how forging those relationships is so incredibly important, as it is in lots of areas of medicine, but particularly so here. And I'd like to pivot a little bit, and I promised that we would talk a bit about kind of space physiology, and I'm afraid I might start off with a bit of a broad question again, but what sort of physiological effects are we interested in when we talk about, can we start with perhaps short-term space travel?
Yeah, certainly lots of different elements to think about, and it depends exactly what you mean by short duration space travel, whether you're talking about kind of a parabolic flight where it's seconds, or whether it's a suborbital flight where it's minutes, or the old shuttle missions of a couple of weeks are considered short duration space flights. So it depends which within those you're talking about, but we can kind of mix them together a little bit.
I'd more considered long term being kind of tens of days and shorter term being shorter, but I'll be honest, it wasn't something I hadn't broken it down like that. So I'll let you decide where to go from there. Perhaps we could go from the minutes onwards and see where that takes us.
So I normally think about these in terms of the stages of the space flight, and so what the physical exposures will be, and then what effect that might have on the physiology or medical considerations. So you've got launch to start with, the potential increased accelerations that you're, depending on which body position you're in, but normally they're reasonably tolerable during launch. Re-entry can be a bit different depending on how it goes, but acceleration is the first bit, and then once they get into space, it's the loss of the acceleration, so going into free fall, or kind of the weightlessness of microgravity floating in space. And as we're kind of stood in the 1G environment of Earth, normally we've got Earth's gravity pulling the fluid down. So the first bit that's noticed when they get into that microgravity environment is the loss of that normal hydrostatic pressure gradient. So you get a kind of central fluid shift, which results in a kind of puffy head, because you've got a headward shift of fluid, and then loss of fluid in the lower legs. So physically they look a bit different, but it can cause congestion and kind of nasal stuffiness in the first minutes or days that they're in space. It potentially causes some other things that we can come back to in a minute. But in terms of the short duration exposure bit, in the first few days, they're then looking at orientating themselves to a new working environment where the floor can be the ceiling and the walls can be the floor or the ceiling. So people can enter a room at very odd angles from what you're used to, which is likely one of the big contributors to space adaptation syndrome, or space motion sickness, which typically affects them within the first 1 to 3 days when they're in space. And they do plan the mission activities around that to reduce the requirements on the astronauts when they first get into space. So you wouldn't plan on someone going and doing a spacewalk in the first day or two, because you definitely don't want to be vomiting inside a spacesuit. So they're probably the first bits that you'd go into. As you're then in space for longer, you're looking at your body adapting to the weightless environment. So as we are on the terrestrial Earth-based environment, we walk around and we resist gravity, and so there's a continual day-to-day training of the body in terms of the anti-gravity muscles and the locomotor muscles, particularly of the lower limbs. In space, you're floating in an almost kind of fetal position, and you move around mainly using your arms. So you can imagine, because the body is incredibly adaptive in kind of almost any environment we can put them in, so it's responsive to the force environment that it's getting. So in the setting of space, you start to get an adaptation of the musculoskeletal system. Compared with Earth, you'd consider it a deconditioning state, but it's just adapting to the space environment, because you don't need to have the strong leg muscles for walking around, or the spinal stabilization muscles, because they're just not needed in microgravity. You also then get as well as the muscle degradation or adaptation associated there, the skeleton also starts to adapt, and so you get a loss of bone mineral density, again mainly in the what on Earth would be the load-bearing structures, in terms of pelvis, spine, lower legs.
I think it's amazing how rapidly some of these changes can happen, and indeed I think we see the same thing in Earth with people incapacitated, particularly in the context of intensive care units as well, that muscle mass and loss of bone density can be incredibly dramatic within a short period of time.
Yes, absolutely, and the important role that the nutritional side of these things play, as well as potential countermeasures and exercise, or physio, or other things depending on what the setting is. Certainly, yeah, it's remarkable, and lots of translational elements between terrestrial healthcare and space health and performance.
And I wonder what sort of exercises are astronauts actually doing in order to prevent this? Because I don't know quite how well this will work as an example, but I think when we typically seek to exercise on Earth, we probably ignore quite a few muscles that we use naturally as postural ones, the muscles in our neck, muscles that actually are working all the time, but we don't normally purposely exercise, and we don't normally even notice our functioning. So to what extent do we have to alter the exercise we're doing in order to make sure everything is covered in a way?
Great question, and it's evolving. And again, this is one of the areas where they have been able to do a bit more research, both in terrestrial bed rest studies, where it's a bit like as you mentioned, intensive care populations, but healthy individuals in bed rest studies to see how the body adapts, and then how exercise countermeasures might help. And so they've evolved the exercise countermeasures over time. They're mainly targeted, as you'd expect, to address the adaptive changes that are occurring. And the two drivers for the exercise countermeasures are to try and limit the adaptation in case people need to do spacewalks. So extravehicular activity in spacesuits is remarkably physically demanding. So they need to try and maintain their cardiovascular fitness, but also strength for spacewalks. So that's one of the drivers. And then one of the other drivers is so that they aren't deconditioned in the Earth environment after the space flight. So the exercise countermeasures aren't, from that angle, to keep them being able to perform in space. It's more than they need for the space environment, but so they can still function and operate when they come back to Earth's gravity, or in future when they get to Mars, as you look forward to those kind of missions. Early on, it depends what they can do. So exercise machines are quite challenging. They've got to have a significant amount of vibration isolation. So if you've got someone running or jumping up and down in the spacecraft, if they're not isolated from the vehicle itself, those vibrations go through the whole vehicle and can end up shaking apart kind of sensitive bits of the structure, or interfering with sensitive research experiments that might be looking for a particularly stable platform. So it's not as straightforward to put an exercise device in space as it would be to put a new cycle ergometer or exercise running machine in the gym. So that is constrained slightly what they've done. But over the years, they've had exercise bikes, running machines, variations on weights machines, and it's trying to hit some of the cardiovascular adaptation that can occur. So you get effective cardiac deconditioning in microgravity. So the exercises try and counteract that, but also to try and target some of the muscle groups that adapt to the space flight environment and the bones. The resistive exercise seems pretty effective over the last 5 to 10 years with the most recent resistive exercise devices for upper and lower body loading, both in terms of the muscle and the bone side. The latest exercise countermeasure devices they're looking at, though, are based on jumping, because that's the resistive exercise devices are very effective on the muscle. They're pretty good on the bone, but not completely preventing it. And some of the thought is actually you need slightly higher impact loads that you can get through jumping. So they're looking at how do you recreate a jump in a weightless environment. So that's some of the work that they've been doing at the moment. Hi-Fi FM is one of the devices they've just tested on parabolic flights.
And to what extent can you mitigate against some of these effects just by establishing a higher baseline before astronauts actually take off to begin with?
Yeah, so certainly that's where the data are tricky to interpret and tricky to understand exactly what's happening, because if you've got someone who has a lower baseline fitness and you get them on into space where they exercise for 2 hours a day most days of the week, that can be a huge step up in exercise. So actually for those individuals, they look like they're doing relatively well in space compared with their pre-state, whereas someone who is particularly fit and does a lot of exercise on Earth before they fly, they could appear to adapt more or decondition more in space. So that's the sort of the pre-state can affect it in different ways. So it can be they're fit and therefore they maintain it better, or it can be they weren't fit and actually it looks like they've improved while they're in space. It also then depends on how well the individual engages with the exercise countermeasure program. So if you tell someone, right, you're going to run for 20 minutes, cycle for 20 minutes, do 20 minutes of weights, and then do another half an hour of running, they control the resistance of the devices. So actually those two exercise sessions won't be the same for two different individuals. They can choose how hard or not hard they're working. So actually, even where they've got the same exercise intervention across a population, it's not really the same. So it's very difficult to interpret where things are working or not working. But certainly, I think it makes sense that if you can get them in a good condition beforehand, that's a good state to be in.
Because I can go for a 25-minute run and count as my exercise done for the day, but as far as I know, we're talking about a bit more than that, up to kind of a couple of hours a day, every day for this, which is, yes, obviously adds a bit more of a, particularly if you combine it with all the other pressures that people can face in space, whether it's kind of psychological or space adaptation syndrome, as you've mentioned, or I know I've seen back pain mentioned as something that's quite common early on, then you do have to think about the human factors involved in this, even in kind of highly trained astronauts.
Yes, and certainly back pain is something that they get in space. It's something they can get after they return from space. And there's interest in the causation of that, but also the countermeasures. So they've looked at whether you can specifically train to activate your kind of core stabilization muscles to help train them in space, or to recondition them once you're back on Earth, which is an interesting particular angle there.
The other thing that I was wondering about, in fact, I've got the information in front of me right here, which says that actually the current record for time spent in space is 438 days by Valery Polyakov in 1994 to 1995 on the Mir space station. Presumably, this goes beyond lots of the models that we're able to use on Earth, for example, in microgravity conditions. To what extent can we almost extrapolate, particularly when we look forwards to longer missions, and I know there's all sorts of things about kind of missions to Mars. To what extent can we predict what the long-term effects are going to be of spaceflight?
Yeah, it is tricky. And as you say, a lot of the analog bits won't look at all of the stresses of spaceflight. So they certainly are doing long duration terrestrial space research analogues that can look at some of the isolation and confinement and some of the psychological aspects. That's certainly something that can be looked at, but the longer term effects of the microgravity or the partial gravity once you're on Mars, they're very difficult to simulate until you're actually doing them.
And do we have reason to believe that the effects of longer term space flight are likely to mirror that of, I say short, but the ones that we've already seen up to a year, that they will mirror those but just be slightly more extreme and people will go slightly further down the paths of adaptation? Or do you think it could throw up further, I guess, physiological considerations that just weren't apparent at all before?
Yeah, I think a few different aspects there. So the shuttle missions were typically only a couple of weeks. The shuttle was the American way to get people into space for a couple of decades, which stopped flying over 10 years ago now. The Russians, by comparison, have had much longer duration spaceflight exposure, as the example you mentioned there. So they've started to build a bigger evidence base in terms of the physical, but also the psychological aspects of the long duration spaceflight. With the International Space Station, missions quite often are 6 months. So that has pushed the international community's understanding of the physical and the psychological aspects of those duration missions. But a mission to Mars, for example, would typically take 6 or more likely 9 months to get there, and then they'd have a prolonged period of maybe a year or so on the ground, and then another 6 or 9 months to come back. So in terms of the isolation, you're looking at maybe a kind of 3-year mission, and there are the psychological ground-based simulations looking at those durations, but not looking at the microgravity or partial gravity effects. To try and address this a little bit, is one of the drivers for the longer duration ISS missions they've been doing over the last few years, where they've extended them to a year-long stay on the International Space Station, to try and get a little bit of a step closer to that. But it's still going to be challenging, and there'll undoubtedly be quite a bit of uncertainty when they do send them further afield, and a big area of uncertainty will also be the potential effects of radiation, which we have increasing amounts of experience within the protective magnetic shield of low Earth orbit, but actually just going to the moon will be a whole different radiation challenge for longer durations than they did during the Apollo, and then going on a Mars mission is a great deal of uncertainty around that. Going back to your other point in terms of what we can expect with these longer duration missions, and if there'll be new things we don't know about, almost certainly. So two of the big things that have happened in the last decade, one was concern about a decrease in astronaut visual acuity, which they then recognised was associated with a bunch of other changes going on in the eye, and that's driven a whole kind of decades worth of research to try and understand whether these what the cause is. So one of the theories is it relates to raised intracranial pressure, and one of the concerns is are these changes going to continue with a longer exposure in spaceflight, or do they kind of plateau at an acceptable level? But that wasn't known about 15 years ago. So that's one example where something new's happened. And then more recently we had a research study was looking at venous blood flow just at different sites around the body, and an incidental finding was that of jugular vein thrombus. So this was something that hadn't happened in space before. It wasn't thought that it was going to be a risk, and yet research study finds it as an incidental finding that then required them, the affected astronaut, to be anticoagulated and treated. And there was the decision around, can they stay in space while this happens? Do we stay and treat them, or do we evacuate them now? As it was, they elected to treat them in space, which all went well, and then brought them back safely. But that was an unanticipated medical complication of spaceflight. So that to me suggests we still don't know lots about it, and as we go on the longer duration missions and go further afield, almost certainly there'll be new and unanticipated medical complications that we'll have to deal with, or physiological effects. And one of the unknowns is people on spaceflight so far have always been able to see the Earth. So one of the concerns from the psychological and the isolation and distance effect is how will they cope on a mission to Mars, where all they can see outside are little stars in the distance, and they've lost that connection and proximity to the home planet.
And certainly I imagine thinking about who might be suitable for a mission like that relies on quite a few unproven proxies for, I guess, their own personality, really, and their psychological state leading off.
Yeah, certainly. And it's a fascinating area as to how do you select in the right people? What evidence base can you use from Earth-based expedition environments where solo explorers or team explorers or teams working on Antarctic bases or other kind of remote places around the world. And there's lots of work to try and learn from those different settings, but then also lots of work to try and look at how you bring together a cohesive team and how you can train them to work together to overcome any conflict or issues that almost inevitably will arise. I'm going to have to wrap up, I'm afraid, looking at the time.
I'm sure we could have ended up talking for ages, but it's very kind for you to speak with me today. And perhaps I could finish just by asking, perhaps, what are you most excited for in the future of research related to this field?
For me personally, I'm incredibly excited by the prospect of humans returning to the moon and potentially following on from the exploration missions back to the moon, having a permanent human habitation on the moon. And both for the science that will come from that, but also the foundations it will lay for future human exploration of Mars. I think it's just incredibly exciting to think about humans doing those things. Professionally, there's also a lot of great challenges to overcome in terms of spacesuits, the biomechanics, the life support, that interface between the human and the system that's required for spacewalks and spacesuits, which is where I particularly find professional challenge and satisfaction. So, and it's an area that I'd love to do more work in.
I'm sure you'll have no shortage of work in the future relating to this as the field grows larger and larger. But once again, thank you so much for speaking with me, and have a lovely rest of the day.
Thank you for having me on. It's been great chatting to you. Thanks very much.
Thanks for listening to the Pager podcast. If you've enjoyed it, do leave us a review, share it with a friend, and come back to listen to our other episodes. As ever, we'd love to hear what you think. You can reach us at Pager Podcast on Instagram and Twitter, or email us at pagerpodcast@gmail.com. Bye for now.